Practice Update. I'm Dr. Farzana Hafizullah. Today I'm welcoming Dr. Marc Chamberlain. He's the Medical Director of the Neuro-Oncology Unit at Fred Hutchinson Cancer Research Center at the University of Washington in Seattle. Dr. Chamberlain, wonderful to have you here today.
Thank you.
So today we're going to talk about some of the updates, some of the clinical trial results that came out and how that impacts clinical practice and our scientific community. Let's talk about the EORTC trial.
So the EORTC trial was launched almost contemporaneously with a larger Dutch trial called BELOB, smaller Dutch trial, which is a randomized phase 2 trial, and suggested for the first time, since we've not had a randomized trial comparing Bev or Avastin for patients with recurrent glioblastoma to a more standard therapy such as a nitrosourea, in this case lomustine.
Yes.
And that was highly suggestive that actually the combination of the two drugs,
Yes.
Avastin plus lomustine, would be the most effective regimen. And for a period of time since that publication, which was in midnight 2014, changed practice. And we all shifted from using Avastin or bevacizumab for recurrent glioblastoma to using this combination of drugs.
Yes.
And so we were eagerly anticipating the EORTC 26101 trial that was to inform us and confirm in a much larger randomized phase 3 manner the results of BELOB.
Sure.
Much to our surprise, and I would say dismay, that did not prove to be the case. So looking at overall survival as the primary endpoint of the study in over 300 patients, the trial suggests that nitrosourea as a single agent is as effective as either a nitrosourea in combination with Avastin, and that is practice changing.
Absolutely.
Because this now suggests that perhaps there is no survival advantage with Avastin, and then therefore, what is the advantage in using this in patients with recurrent glioblastoma? And so our concern is, will this change the accelerated approval that Avastin was given for recurrent glioblastoma by the FDA? The EMA, the European Medical Association or agency, has never approved it in a more Catholic manner through Europe for use, but it's been used many times in clinical trials. And it has been our sort of standard go-to non-clinical trial regimen as a salvage regimen for patients with glioblastoma. And I think the outrage by patient advocates is going to be huge if we go through a similar process as we have with breast cancer, where an accelerated approval was given for Avastin for breast cancer and was later withdrawn with 2 randomized trials that showed fairly meager results.
Absolutely.
So this is concerning, because this has really been quite an active agent. At least our belief, it's been an active agent now for nearly 6 years, and that's practice changing.
It's absolutely practice changing, and as you said, to the dismay of many who've used this particular regimen, we're hoping to see something positive. So now, how is this going to change the scientific approach? How do you expect it to change? Some of the clinical trial design, maybe looking at some more of the molecular targeted type of therapies out there. How are we now going to step back and refine our approach just based on the results and what's happened with this particular trial?
Well, Avastin has been, in many recent trials, used now as the comparator agent in recurrent glioblastoma.
Yes.
So this is going to require a rethink.
Yes.
And is there going to be advantage now of taking Avastin forward in our particular landscape? And I think that's an unanswered question, that we may be obliged then to revert back to using nitrosoureas as our standard comparator arm in trials going forward, and not using Avastin. Where that becomes fairly complicated is there are trials that are already designed, trials that are operational, that still have Avastin as a unique component of the treatment regimen, whether it's standard or an add-on. And so this raises enormous issues.
Absolutely.
And this is going to take some time to sort through. I think before publication, before larger regulatory agencies have an opportunity to adjudicate on what's going to happen with Avastin, probably for the immediate future, nothing changes.
Sure.
But something will change.
Something will have to change, absolutely. And just the diversity of the tumor itself, having that precise look, that more personalized look at the disease state and the patient, is probably going to be the focus as well. We would welcome you to come back at another time. But thank you for watching Practice Update today. I'm Dr. Farzana Hafizullah with Dr. Marc Chamberlain. Thank you. For more advances in neuro-oncology, visit the Brain Cancer Center of Excellence at practiceupdate.com.